Abe Mollalo is a faculty member. So we've had faculty and 2 students, an MPH student and an MD PhD student. And now we are back to a faculty at Baldwin Wallace University, and he's going to be talking about the application of machine learning models and predicting the hotspots of age-adjusted mortality rates of lower respiratory infection in the USA. So Dr. Mollalo, welcome. And I'm going to ask you to share your own PowerPoint. There's an icon at the bottom of the screen. And if you could share your PowerPoint. And we have the timer, as you've seen. And the timer is going to give you 6 minutes of green, 1 minute of yellow, and then it'll ring for the,
I think, thank you very much, Amy. I think my presentation is going to be more than 6 minutes, a little bit, a few minutes more than that.
Okay.
Probably less than 10 minutes.
Okay. If you could introduce yourself, and then you can go ahead and start.
Thank you very much, Amy. So good morning, everyone. I'm Abe Mollalo, Assistant Professor of Public Health from Baldwin Wallace University. I hope you had a wonderful day so far. So in this presentation, I'm going to briefly talk about our research project on mortality rate of lower respiratory diseases using machine learning techniques to predict the location of hotspots in the United States. So let's start with some basics. Lower respiratory infections are bacterial or viral infections that occur below the larynx. So in this picture, which shows respiratory system of a human, here is larynx, and below the larynx, we can see trachea, bronchi, lungs, which are related to the lower respiratory system. And above larynx is upper respiratory system, which is not the subject of our presentation. So lower respiratory infections consist of a range of lower respiratory diseases, but the main diseases are pneumonia and also bronchitis. And it should be noted that almost 90% of lower respiratory deaths attributed to the pneumonia. And if an individual is diagnosed with lower respiratory, the main symptoms that he or she may have are wheezing, chest pain, coughing, fever, and also fatigue. So according to the World Health Organization, WHO, in the year 2016, almost 2.5 million deaths were reported because of the lower respiratory infection across the world. And the disease is a leading cause of deaths among young children and age group less than 5 years old, and is the number 6 leading cause of deaths for all ages. And in the United States, which is our study region, our study area, every year it poses a huge socioeconomic burden to the healthcare system. Almost $9.5 billion a year is spent for treatment and prevention of the disease. It's also the most common cause of hospital admission for adults in this country. So this map shows a spatial or geographic distribution of LRI mortality worldwide for all ages. As you can see, mortality is highest in Central Africa, and in the United States, it's between 25 and 49 cases per 100,000. And among children less than 5 years old, again, mortality rate is highest in the Central Africa. In the United States, that's very low mortality rate. It's between 0 and 4 cases per 100,000. But among elderly people, it's more serious. People with age greater than 70. In the United States, it's between 120, 250 cases per year, per 100,000 in the United States. So there are a few, very few studies that focus on the geographic aspects of the disease, of the lower respiratory infection. And to our knowledge, nationwide geographic distribution and modeling of the lower respiratory infection has never been investigated. So to control confounding effects, we obtained age-adjusted mortality rate of lower respiratory from JAMA for 8 years, starting 1980, 85, and all the way up to 2014. The data were available at the county level across the United States, and we assume that all reported cases represent the status of the disease in the United States. And also administrative boundaries of counties obtained from Tiger Line, and we joined the mortality rate to the corresponding location in ArcGIS for each year separately. And for geographic modeling, we collected several explanatory variables such as climate data, minimum maximum temperature, total precipitation, fine particulate matter, PM2.5 to represent air pollution, sunlight. So these data were obtained from the CDC Wonder. Smoking prevalence for male and female obtained from a published paper in Population Health Metrics. And digital elevation model was used to extract elevation and also maximum slope for each county. And the data were obtained from the USGS and prepared in ArcGIS environment. And finally, a broad range of socioeconomic variables such as proportion of white and black population, median household income, poverty, and so on were used as explanatory variable, and the data were obtained from the American Fact Finder. So in this research, we are interested in finding answers for this question. So which counties persistently identified as hotspots of LRI from 1980 to 2014, almost 35 years? Which factors could explain presence or absence of the LRI hotspots? And finally, which machine learning techniques or machine learning algorithm had highest accuracy in predicting the location of the hotspot? So first, we use global clustering techniques such as global Moran's eye and general G to statistically examine the type of distribution. Is there any clustering or not? And then if there is clustering, we use local indicator spatial autocorrelation or LISA to identify the location of hotspot. And finally, 5 different machine learning classifiers, logistic regression, random forest, gradient boosting, and SVM, were used to predict the location of the hotspots. So the results, global Moran's eye showed that for each year the distribution was clustered, statistically significant. Then we plotted the Z-score, which shows the intensity of clustering. And as you can see, the distribution is becoming more clustered and random over time. And the same for general G, another clustering technique. And as you can see, the Z-score after we plot for each year, it was significant, clustered, and the Z-score increased. And it shows that the distribution becomes more focused and focused. So, but the question is, where are the hotspots of LRI? So for this purpose, we used local indicator spatial autocorrelation for each year. And here is the result of LRI, of the LISA, local indicator spatial autocorrelation. You can see as we move from 1980, 1985 on all the way up to 2014, the distribution of hotspot or red counties becomes more focused or less dispersed, and which confirms the result of the global Moran's eye and general G. And also there was a shift in the distribution of hotspot. If you look at the distribution, so it was first in the western part of the US, but as we move forward, the distribution moves to the southeastern part of the eastern and southeastern part of the United States. So in the next step, we intersected the location of the hotspot to identify which counties were persistently identified as hotspot. And we ended up with only 77 counties. And it's interesting that 81% of the hotspots only occurred in these 3 counties in Georgia, Kentucky, Virginia. And this suggests that these areas are persistently identified as hotspot of LRI and require closer attention. During the 35 years, they are still hotspot of the lower respiratory infection. And here is the result of accuracy assessment. So because of the data, we were imbalanced. We use the precision recall curve for all models. And as you can see, this one, gradient boosting, at the highest area under the precision recall curve. And we consider this as the best classifier to identify the location of the hotspot. And so all of the models had a relatively high accuracy in predicting the location of the hotspot, but decision trees, gradient boosting, and also random forests obtained the highest accuracy F1 score, precision recall curve, area under the precision recall curve, and with 92% overall accuracy on the independent dataset or test dataset. So in summary, geographic distribution of, I think I forgot something. Yeah, so the GBT model indicated that spring minimum temperature, there is a positive association between the spring minimum temperature, winter precipitation, and median household income in locating the hotspot. So in summary, the geographic distribution of LRI mortality in US was clustered and is becoming more focused. Hotspots shift from west to southeast part, and some counties were persistently identified as hotspot, indicating that public health policymakers should pay closer attention to these areas. And decision trees, random forest, and gradient boosting had the highest accuracy in locating the hotspot. But it should be noted that the findings are only applicable at the county level, so we can't make conclusion at the sub-county or individual level. However, for targeted interventions, it is highly recommended to perform analysis at the sub-county level, such as zip codes or census tract. Thank you very much.
Thank you, Dr. Mollalo, for your presentation. At this time, again, the chat box is open in case you would like to enter in your question, or you can just open up your microphone and ask any questions. So I have a question. You said that it seemed like a lot of the hotspots seem to be clustered around the southeast area of the United States.
Mm-hmm.
Can you suggest a reason why?
Oh, that's a very hard question, honestly. So we can't say that. So we can't say for sure what is the reason there is a shift in the distribution, but the variable that could explain the location of the hotspot for the year 2014 were temperature, precipitation, and income with the very high accuracy. So, but the main reason probably is not, we don't know that.
Yeah, sometimes you may try to think of some possible reasons. So I was just wondering if you've thought of potential reasons for that.
I don't know that.
Okay. Oh yes, go ahead, Dan.
I can't remember exactly what you controlled for, but did you control for tobacco sales as a part of the county's outputs? Like if tobacco was grown in those counties?
No, tobacco smoking was an explanatory variable, not a. It didn't control for considered as a confounder. No, it's an explanatory.
Because I was really thinking about the map looks very similar to where tobacco is grown in the United States historically and currently.
That's a great thing. Thank you very much.
Yeah.
Look at the spatial distribution.
When you're smoking, you're reducing your immune system and put yourself more at risk for a lower respiratory infection.
Is it the distribution is similar to the geographic distribution of the tobacco? The distribution of clusters?
So the per capita sales of tobacco as a total market output, I think, is what the map is in those counties. Like if tobacco is the largest product of the county, then it correlates very similar to the map.
Thank you so much. Thanks.
Krista, did you have a question?
I did. That's very interesting. And I'm wondering, like Dr. Lee was saying, so is, that cluster that you found, is that part of your next steps and your, with your research that you are going to look into?
Sorry, I didn't hear that what you said. Sorry.
Sure. So, like Dr. Lee was saying, when you found that cluster in one specific region, is that something that you're going to investigate further in future research?
Yeah, so clustering kind of is the first step for generating the hypothesis. So what is going on here? And but in the future research, we're going to not looking at the variables that can explain the cluster because it's just 1 and 0 is a binary classification. In the future research, we're going to work on the predicting the actual rates using the machine learning techniques. So not the cluster 0 or 1.
Okay, that will be very interesting as well.
Thank you very much.
Any other questions for Dr. Mollalo? If not, I want to, at this time, thank all of our presenters for our first ever virtual public health academic forum. And I thought all of the presentations were fabulous. Thank you so much.